But
That's different.
sometimes it's scary, especially for cancer survivors like us in remission. We finish treatment and then you read of some other women who maybe 2-3 years down the line, they are re-diagnosed, even in the same spot, with having their cancer has come back. What causes this?
So, one of the most common risk factor for a woman to get cancer is history of cancer. Because you have that gene inside you which give you first cancer, and later on it can give second one too.
Oh,
Now
wow.
that's a very, very deep science. Scientists are looking into these genes and trying to find out why some cancer survivors have relapse and some don't. There is a lot of questions we don't know in cancer yet. So this is one of them. Because that's a very important, very, very important thing to understand. Can we devise a test, any kind of test, which will tell us who are the patients who are diagnosed with breast cancer will get another one, and which are the ones who will not? Problem solved.
Exactly.
Then we know who are the patients who we need to follow very closely, and who are the one we don't need to. What are the patients who need chemotherapy? What are the ones who don't
need.
So answer is genetics. And we do have 2 or 3 tests in breast cancer coming up, but they are not 100% yet. So they give us a lot of information right now, but mostly in early stage cancer. When we go up to this advanced stages, those things don't, help much.
Help much. But I was reading something about Angelina Jolie, about her having the BRCA testing.
Yes.
Since her aunt had it, her mother had it, and everything. Is it the same type of gene testing you're talking about, or is it absolutely different?
No, absolutely different.
Okay.
What she got a screening test, a screening BRCA testing. She didn't have cancer.
Right.
The test I'm talking about is when you diagnosed with cancer, and we are doing these genetic testing on the cancer, on the
Itself.
tumor cells itself.
Right.
So this is different.
Right.
That's risk. This one you have it, so we need to know the prognosis. Like how are you going to do with the treatment, or in fact what kind of treatment is better for you as compared to somebody else who has cancer.
Who has the same thing?
Yes.
Yes. When I was diagnosed and everything that I went through, you were in sync with a surgeon who, unfortunately, he's not here with us, but I'm going to be interviewing him, a very close friend of yours. Why is it that the oncologist and the breast surgeon are always in sync? Because you guys were like 5 and 6. You worked together, not just on me, I saw with other cases after oncology surgery. Why is that relationship very synchronized?
That's a very good question. So not only medical oncology and surgical oncology, radiation oncology too.
Yes.
This disease needs a multi physician approach. We cannot just treat cancer. One person cannot treat cancer. We need a team. We have to have a team. We have to have doctors who understand each other, who can work with each other. Because when I diagnose somebody with cancer, I cannot do surgery. I cannot give radiation. My main role as a medical oncologist is to act as the main person who's managing this patient. I see a patient who has cancer and I want to start chemotherapy. Now that patient need a port. So the benefit of me and Dr. Sugiyama, who's my friend
Yes.
and colleague, who we were working together, benefit was I can pick up my phone and I can call him, Sugi, I need this patient to have a port tomorrow.
Yes.
Because we need to start chemotherapy
Immediately.
on Monday.
Yes.
Because cancer treatment and timing, there is a relation between it. If you delay cancer treatment, your cancer can go from stage 1 to 2 or 3 or maybe 4 within a few weeks and months. And if we keep delaying these things, if I have a surgeon who I don't know, I send a patient and surgeon don't see patient for next 4 weeks, 5 weeks. That treatment is delayed for 6 to 8 weeks, and which is happening in Brooklyn a lot. There is a big lag time from the diagnosis of patient with cancer in Brooklyn and start of treatment. That's what we are trying to minimize by providing a center where when you come in, we take care of you right away.
Yes.
So it was very good, for last 5-6 years. We worked very well together. We'll see if we can bring him back to Brooklyn, actually.
I hope he does. I saw him almost 2
Yeah.
weeks ago. I hope he comes back.
Sure.
When I was diagnosed, I met and I started treatment. I was here, made a lot of friends and all that. In fact, not here, in the other
In
place.
the old
You have-
place.
You have expanded since then. Praise God. There were some women that I met that had undergone surgery first before having chemo. I was now having chemo first before the other treatments. Why is this so? Why is the reverse the case?
Yeah. So, as I said before, there are different types of cancers, and similar type of cancer also has different stages of cancer. Somebody who has stage 1 cancer has totally different treatment as compared to who has stage 3 cancer. So, in your case, we were at stage 3.
Yes.
That's why what we try to do, we try to bring your stage 3 to stage 1, which we were actually able to do that.
Very successful.
But if patient has stage 1, they will go for surgery first, and then we will know if patient will need chemotherapy or not. Not everyone need chemotherapy, first of all. So, but if someone comes in with stage 3, then sometime we give chemotherapy upfront, which is called neoadjuvant chemotherapy. What that means is chemotherapy before your surgery. And when we give chemotherapy after surgery, is called adjuvant. So that's to give chemotherapy to prevent that cancer to come back.
Yeah.
So you got neoadjuvant chemotherapy.
Because I did it before.
Yes.
Yes. Okay. Now, sometimes we get, like you said, you go on the internet, and ever since this has happened to me, I think I will be writing my thesis on cancer very soon, because there's just so much here.
And you were on internet all the time. Yes. I know.
You know, I'm always asking you questions
Yes.
and everything.
Yes.
Dr. Khillan, would you say that because we read a lot and all that mammograms actually add to the risk factor for breast cancer? Or is there any other alternative to having mammograms to be able to, as a prevention before attacking it if there's cancer?
So I definitely want to say something about mammogram. Mammogram is, I think, the most important test in a female's life, which can find out these cancers very early, in like such an early stage that treatments are very simple. Though do involve surgery, but they're very, very simple, very small form of surgeries, instead of giving chemotherapies, doing big surgeries. Very simple. Now, when we talk about mammogram, we should start getting mammogram. Women should start getting mammogram when they are around 40-year-old. But if you have a family history of breast cancer, you should start getting mammogram 10 years before that person got her cancer. So for example, if somebody has a mother who got diagnosed at 42 with breast cancer, should start getting mammogram at 32.
Right.
Now there's a little issue with mammogram is when you are young, younger women tend to have dense breast, so mammogram is not that sensitive in very dense breast. So what we do is we do mammogram plus sonogram, ultrasound together, which gives us pretty good picture.
Results, yes.
Very good results. So, but as I said, it's very important. We don't have any alternative yet, but there is new techniques coming up in mammogram. We are having digital mammograms now. There are some other new techniques which are developing. I know mammogram is not a very pleasant test to have, and definitely we need something better. I think give it a year or two, There's a lot of development in technology. What happens in medicine, whenever something comes up, to get it from the lab to the shop takes years and years and years, because it has anything which we use for patients, for human beings,
Yes.
goes through so much testing, so much regulation, takes 10 to 15 years. But I think we are very close to having something better than mammogram. But as of today, mammogram is the gold standard test for screening of breast cancer.
Great. Apart from the physical aspects of cancer, I mean, what we go through as cancer patients, grueling experiences. Your body is off to the left field. The mind at the end of the day matters on how best you can really plug into what's happening to you and contain it mentally. Before coming to the mental resilience side of it, there's also a report that I read that people like us, some time down the line in future, had PTSD and were, very, very, went into a state of depression and certain things happened, some decide to take their lives. Why is this so? It's not as if PTSD is always synonymous with somebody that has gone into the army and has gone to Afghanistan and come back. Could PTSD actually affect cancer patients like us?
Absolutely. The name itself, the disease itself, we are treating cancer from years now, but the success is in last 5 to 10 years. If you talk about cancer to somebody, let's go back 10 years and let's see what was happening in cancer. I will give you an example of lung cancer. Survival for metastatic stage 4 lung cancer was 14 months with best of the treatments. Within last 5 to 10 years, it went from 14 months to 3, 4, 5 years. So, but we still know 10 years ago what happened to cancer patients. And it has engraved in our brain that cancer is a death sentence. Stage 4 heart failure, right? Stage 4 heart failure, patients' average survival is 3 to 6 months. Stage 3 breast cancer, which you had, 70 to 80% women will live for more than 10 years, maybe 20 years. But if you hear somebody has stage 4 heart failure, what comes to your mind? Nothing, right? It's not as bad.
It
doesn't look as bad as cancer, but
yes.
But look at the survival. It's one of the worst disease.
It is.
But you never heard, oh my God, this guy developed congestive heart failure. But if you hear, oh, that person has cancer, oh my God.
True.
So that's our mindset. That's how we look at cancer. That once you have this word in your diagnosis, you're like, oh my God,
Yes.
that's it. End of the word.
Yes.
Which is not, but that's how we feel.
Yes, because I remember when I got my diagnosis and I sat in front of my PCP before I met you.
Yeah.
I mean, I just started to think to myself that I should start putting my house in order.
Yes. See?
I didn't think I'd be sitting with you now,
Yeah.
2 years later. So
And sitting gracefully.
By His grace. But it is scary when you first hear it. And
Yes.
A lot of women actually end up dying just from hearing the diagnosis. They just sleep and don't wake up.
Yeah.
Just because of that news. It's
It's terrifying.
It is
It is
terrifying.
Yeah.
It is terrifying.
And then all the information on the internet. So, when you read more and more, one thing I want to say, when you are on internet, try to read some good resources, not everything. NCCN, National Cancer Institute, one of the best sites to go there is a whole area for patients to read about their cancers.
Yes, like for the audience and listeners that are listening now, the American Cancer Society, what were you saying?
They have their own website.
Right.
It's called nccn.org. You go on that, you can make an account. They also send you emails with information.
Okay.
And it's a very, very, well respected site. People, oncologists from all over the world, they contribute to this website, their thoughts, their papers, their research. The information you get from there is much better than you get from some blog. So don't go to blogs.
I don't do blogs. I don't do.
That's where confusion starts. Like patient
Yeah.
comes in, oh, chemo kills everyone.
Voila.
You're sitting with me.
Yes.
Yep.
Touch wood. Where's the word? Brilliant. Yes. Like you happily mentioned that everybody would be very, optimistic about that. Cancer is no more a death sentence.
It's not.
Compared to many years ago, you hear cancer and, maybe 1 week later you're gone,
Yeah.
just from the thought of it. So looking into the future, do you hopefully think that with all the clinical trials and everything going on now, do you see a cure for cancer,
Yes.
a total cure for cancer, not just going through treatments, a total one-stop shop cure to eradicate cancer?
It's going to take time though. It's not. There is a lot of research happening on nanotechnology. Nanotechnology is, nanoparticles are 100 or 1,000 times smaller than an atom. Atom is really
Yes,
small.
tiny.
1,000 times smaller than that. And nanotechnology is coming up, and it actually, you can have like a small piece of gold and you can put like treatment on that part of gold and inject in the blood, and it can go to the tumor and kill it. But not yet. We are not there yet. So there are a lot of fascinating research is happening in cancer, and I think it will be at some point we will have better treatments. But you know what I think? What's going to happen? We're going to have some blood tests which are going to come up, and they're going to tell us before even you develop cancer that this is the gene which may cause some problem. Let's fix it. Very fancy stuff.
Awesome.
I don't know who's going to pay for that.
I was just about to ask that.
They're going to be very expensive, but I think nothing is expensive than human life. Every human's life.
Oh, sure.
So I think we are going in that direction. And to add that, your PTSD comment, I'm going back to PTSD comment.
Yes.
The reason for this room, this is our infusion room, as you know.
I know.
And look around. I didn't put chemo chairs.
At all.
And the reason I didn't put chemo chairs so that my patient don't have PTSD. They come here, they chill out on these
Relax.
recliner, they relax, they watch movies.
Exactly.
I don't want them to have that impression while walking into these infusion rooms to see those chemo chairs and think that, oh my God, I'm dying from cancer. I want to think when they come in this room, think I'm going to live with this cancer. I'm going to
Exactly.
beat it.
Exactly.
That's the whole idea of this room.
Yes. And which brings me back to the different types of cancers. Some we have to be infused, like I was. Some they have oral medications. Why is that?
Yeah.
Is it one is worse
Yeah.
than the other? Or
No. It's not. Okay, so it's not injections are better than pills or pills are worse than injections. All of these treatments are the forms in which these chemicals are stable. Some treatments are stable in water, some treatments are stable in the form of a tablet. There are some chemotherapies we cannot make tablets because they are not stable in tablet form, so we have to do IV. So that's the only reason we do use all different compounds in different shapes. But sometimes there are some chemotherapies which are tablet form, but believe me, they are as bad as chemotherapy.
Right.
And some of the chemotherapies which are IV has no side effect whatsoever, but it's IV. So I don't think having a treatment in the form of IV is worse than having PO.
Right.
So it means that it's stable in water and the other is stable in solid form. That's what it is.
Oh,
Yeah.
wow. Okay. That's great.